All right. Why don't we get started? Today we are going to start. We're continuing our section on social insurance, but we're going to focus for the next several lectures on the healthcare sector. There's a bit of a trade-off, as always. One could teach a whole course on health economics. We used to have a whole course on health economics here at MIT. But I have a lot of other stuff to cover this semester. So I'm going to try to sort of give you a mini course on what you need to know about health economics, to think about the government's role in the healthcare sector, and then we'll talk about how we apply. That'll be the first section, sort of healthcare in the US. Then we'll talk about sort of how we apply the framework of Chapter 12 to think about optimal health insurance. So that's what we'll try to cover today. Music recommendation day, a band called the Jungle Giants, the second band from Brisbane, Australia. I've recommended this semester of all things. This song called She's a Riot is a great pop song, and they're playing on November 9th in Harvard Square. So you should check them out. Okay, so we're talking about health insurance, health economics. This has sort of my favorite intro of any chapter. So I think I'm just going to read the intro to you because I love this intro to the chapter. So on March 30th, 1981, only 2 months after entering office, President Ronald Reagan was shot by John Hinckley, a deranged fan of Jodie Foster who thought the actress would pay more attention if he killed the president. Reagan was rushed to George Washington Hospital, where he underwent 3 hours of surgery to remove a bullet that entered his lung. Though the injury was potentially fatal, Reagan made a full recovery and went on to serve the full 8 years. 100 years earlier, President James Garfield was not so lucky. He too was shot 2 months after entering office on July 2nd, 1881, by Charles Guiteau, who thought God had ordered him to kill the president. Garfield was brought back to the White House, where for 80 days, a dozen doctors attempted to find one bullet that, unbeknownst to them, had lodged itself near Garfield's spine. The doctors probed the president's wound with their unsterilized fingers and metal rods, succeeding only in widening the wound, infecting it, and puncturing his liver. Alexander Graham Bell ran a metal detector, the guy who invented the phone, ran a metal detector over Garfield's body and soon announced he'd find a bullet. Surgeons went to work but still failed to locate it, not realizing that Bell had mistakenly detected one of the bed springs underneath the president. The infection resulting from his poor medical care soon caused Garfield to have a heart attack. And when he eventually died, his coroner declared Garfield would have survived if only his doctors left him alone. So 100 years, most important person in America, and a fundamentally different outcome of the US healthcare sector. That talks about the incredible advances we've made in healthcare in the US over the last 100+ years. It's been nothing short of miraculous. And basically, that's come with a cost. We now spend a lot more in healthcare. So to focus on the more recent past, in 1950, we spent less than 5% of the US GDP on healthcare in the US. At that point, people spent less on healthcare than cars, fuel, or clothing. By 2019, healthcare spending accounted for 17.7% of GDP, 17.7% of GDP, making it the largest single sector in the US. And this growth is not expected to stop. Healthcare spending is projected to grow at about 5.4% a year, reaching somewhere between 40 and 50% of GDP by the end of the century. So basically, the question is, how do we feel about that? Is this a problem? Well, it's not entirely obvious. After all, healthcare sucked in 1950. Okay, babies born in 1950 were 4 times more likely to die before they saw their first birthday. If you had a heart attack in 1950, you were 4 times more likely to die within a year. Or more relevant for the people in this room, if you hurt your knee skiing, you were in the hospital for a week, you're on crutches for 6 weeks, and arthritis the rest of your life. Now, if you hurt your knee skiing, you get arthroscopic surgery outpatient, you're back on the slopes 2 weeks later. Healthcare is just way better. No one wants to go back to 1950s healthcare and 1950s costs. Indeed, estimates in the book called Your Money, Your Life by David Cutler from Harvard suggest that if you take the typical value of the life estimates we used in Chapter 8 and apply them to the improvements in health we've seen from the US medical care system, the raise in healthcare spending from 5% to 18% of GDP has been worth it. We are better off as a country spending 18% of GDP and being as healthy as we are today than we're spending 5% of GDP and having the crappy healthcare system we had in 1950. At the same time, the health system is far from perfect. And one of the primary problems of the healthcare system in the US is enormous disparities that we see in healthcare. Okay, the white infant mortality rate in the US is currently about 4.6 per 10,000. That means that 4.6 per 10,000. That is in line with other countries in Europe. The black infant mortality rate in the US is 10.8 per 10,000, which is comparable to Libya and twice as high as the rate in Serbia. So we have a system which has delivered incredible health outcomes, but also incredible disparities as well. Now, part of the reason for these disparities is the huge number of uninsured people we have in America. Before the Affordable Care Act passed, we had about 50 million people without health insurance in America, by far larger than any other developed nation in the world. The Affordable Care Act helped with that. It attempted to remedy this issue, but it's still true that today we have about 30 million uninsured people in America. Moreover, this has enormous fiscal implications. So as we mentioned in chapter 4, I didn't teach chapter 4, but you covered it in section, or if you read it, whatever. In chapter 4, we mentioned the US is facing a long-term fiscal deficit of about $75 trillion. That is, if you look at the promises we've made to spend, minus the taxes we said we're going to collect, we're at $75 trillion short. Okay, 90% of that is healthcare. If healthcare costs simply would grow at the rate of GDP starting today, almost all the US's long-run fiscal problem would go away. So healthcare spending matters for health, for our physical health, and for the fiscal health of our country. So this is a critically important sector to understand, and a sector in which the government plays a huge role. Indeed, literally 50% of healthcare spending in the US is public and 50% is private. So you have a perfectly mixed system of public and private sectors. And so it's a perfect place to be thinking about what the proper role of the government is. Okay. So what I want to do is start with sort of an overview of healthcare in the US, what you need to know about the basics of healthcare. Then I'll start talking about the role of the government in particular in providing health insurance, as that ties into our social insurance section. But let's talk about healthcare. Once again, I'm only giving you a tiny share of what you should know about healthcare. So please ask questions as we go along if you want to know more about any of these topics. Okay, so in 2019, the US spent almost $4 trillion on healthcare. All I'm doing is all pre-COVID. You know, COVID messed everything up. Well, this is pre-COVID. US spent about $4 trillion on healthcare. Okay, that was, as I said, about 17.7% of GDP. This is much higher than any other developed nation. If you look at figure 15.1, you see healthcare spending as a share of GDP relative to other countries. And you see that we are about twice as large a share of GDP to healthcare as countries like the UK or Finland. And we're larger than even the closest country, which is Switzerland. Okay, so we spend a lot on healthcare, both in absolute dollars and a share of GDP. Where does it go? Well, that's shown in figure 15.2. This shows the distribution of healthcare spending in the US. Hospital and doctors are each about a third of our healthcare pie. Prescription drugs is the next biggest, about 12%. Then there's other personal healthcare services, nursing home care, and home healthcare. Okay, so that's where our money goes, mostly to doctors and hospitals, some to prescription drugs and other sources. Now the question is, yeah.
Are administrative costs represented? Or are they just?
I'm going to come to that in a minute. This is the total spending, including administrative costs. But that's a great segue to the question of, well, let's go back to figure 15.1. Why do we spend so much more than other countries? And really, the answer lies in several domains. Okay. And basically, one answer could be, look, basically one answer could be we spend more healthcare because we get better healthcare, but that's not obviously true. If you look at figure 15.3, what we do here is we compare the US system to Canada, the UK, Germany, and France, 4 of our major competitors. You see our healthcare spending per person is way higher, yet our infant death rate is higher. Our potentially preventable death rate is higher. Folks who went without healthcare for the past year are higher, and wait times are higher here than anywhere but Canada. So basically, our healthcare system seems to be expensive and not delivering a particularly great product. So what's going on? Well, basically, if you look at figure 15.4, this is an attempt by an accounting firm, by McKinsey, by a consulting firm, to try to decompose what is the source of the excess spending on US healthcare. Basically, they argue that there's really several major sources. One, the first and sort of the easiest to deal with is excess administrative costs, or the easiest to explain. We have a very administratively fragmented system. Most other countries have one insurer who doesn't have to advertise and who can process all the claims. Remember, when I talked about arguments for social insurance or market failures in private insurance, I talked about the benefits of large pools for administering insurance. Well, the largest possible pool is a single payer national insurance system. In a typical European country, health insurance administrative costs are 2 to 5% of the healthcare dollar. In the US, health insurance administrative costs are 12% of the healthcare dollar. And that doesn't even count all the spending healthcare providers do to try to comply with the healthcare insurance administrators. That's just the part administrators make. There's also all the money hospitals spend filling all these forms that are different for Blue Cross and Aetna and Medicaid and Medicare, et cetera. So there's a huge amount of waste that comes from our multi-payer system. That's one source of difference. Probably this paper argues a bigger source of difference is that we pay much higher prices for healthcare services and goods than do the rest of the world. That's illustrated nicely in figure 15.5. This is from a study that collected data from, let's see, I don't remember how many countries are collected here. I don't know how many countries are collected here. It's a number of countries. What I do in each of these little panels is I show the cost of something in the US, the average country in the sample, and the cheapest country in the sample. The top panel is for medical procedures. The bottom panel is for medical drugs. So what you see is, for example, for hip replacement, if you look at the same procedure, hip replacement across countries, the US, it costs twice as much as the average country and about 6 times as much as the cheapest country. Every one of these cases, the US is much, much higher than the average country or the cheapest country. Yeah.
Are we assuming that like the cheapest country and the US have like comparable effectiveness of like these surgeries?
Well, that's a great question. That's sort of the previous graph, which is we don't really see better outcomes in the US. The reason we choose these things like hip replacement, C-section, normal delivery, these things we think are done pretty well in lots of places. We're not comparing high-tech neurosurgery, and I'll come back to that. We are comparing sort of generally what we might consider commodifiable services. Services where an appendectomy can be done pretty well anywhere in the world. Okay, I mean, maybe not in the most dire, deserts of Africa, but pretty much everyone in the developed world, they can do appendectomies pretty well, or hip replacements pretty well. And that's why these are chosen. Likewise, in the second panel, it's even a clearer comparison. It's literally the same drug. Literally, it's the price of a drug in different countries. And what you see is basically literally the same drug is much more expensive. Though here, there's no contrast issues. Literally, the same drug is more expensive in the US. Okay. And there's even more striking examples. So there's a study in Vox.com where they found prices such as $937 for toe ointment, $3,500 for intravenous hydration, and most strikingly, a hospital that billed $18,836 for a nap and a bottle of formula. Okay, so our prices are really out of control in the US relative to other countries. Why? What's the difference? Well, it's actually really, really simple. Every other country in the world regulates the prices healthcare providers can charge, and we don't. We're the only country in the world, only developed country in the world, where the prices healthcare providers charge are determined by the free market. Okay? There is no market more broken than the market for healthcare services. Think about every reason we learn, every market failure we learn about in economics. Externalities, we already talked about externalities in healthcare, from my passing the flu on to you to my making you spend more money. Imperfect information, where can we more imperfect information in healthcare, where it's impossible for me to shop around for if I'm in an ambulance and a heart attack, it's kind of hard to shop around and find the best price. Okay. And certainly hard for me to know if the doctor's doing the right thing to me or not. Imperfect competition. Where's the more imperfect competition than for a hospital on Nantucket, where it's an island and literally there's nowhere else to go when you have a heart attack but that hospital. Okay. Every market failure we talk about is paramount in the market for healthcare. Indeed, this is so well known that Kenneth Arrow, the famous Nobel Prize winning economist, wrote a famous article in 1963 arguing about all the market failures in the healthcare market. Every other country in the world has learned this lesson, and they regulate healthcare prices. We don't. And that's the simple answer to why our prices are so much higher than the rest of the country, to the rest of the world. Okay. Moreover, In the back, yeah.
So, I seem to remember that.
No, go ahead.
I seem to remember that in the Inflation Reduction Act, they passed something that lets the government negotiate pricing.
Yes, so we will come to that. So in the Inflation Reduction Act, they actually include for the first time the ability of the government to negotiate the prices they pay for drugs, but it doesn't extend to the private sector. So it does help the government, doesn't extend to the private sector. It's a step in the right direction, albeit a small one. Yeah.
I've heard from like some people in pharma, and I guess I wanted to ask what the validity of this argument is that like, because there's so much high-tech R&D that happens in US pharma companies, having price controls like, and other countries can use this spillover.
Yeah, no, it's a great point. So what we're going to do in probably the third lecture is we're going to spend a bunch of lectures talking about healthcare reform in the US. We'll talk about price controls and what their effects are, but why don't we hold on to that discussion till that point. So basically, the other problem we have in the US, so we have the problem in the US, the patients can't price shop. So it's hard to know what's cheap and what's not. The other problem is the more expensive a drug or the more expensive treatment, the more money providers make. Okay. So for example, if you look, there are 2 drugs that are approved to treat age-related macular degeneration of the eye, which basically is, muscular blindness. Okay. One of those drugs costs $50 a month, and the other one is $2,000 or more. And there's no clinical superiority of the two. There's no evidence that the $2,000 drug is any better than the $50 drug. Yet 1/3 of doctors prescribe the $2,000 drug because they make more money prescribing it. Okay. Another study found that if you look at lower limb MRI scans, literally like anybody can do a lower limb MRI scan. They set them up in shopping malls and stuff. It's not that hard to like tell if you look at your knee and see what's wrong with it. Okay. If you look at people getting lower limb MRI scans, the typical patient, when they go to get their MRI scan, the typical patient passes by 6 places that are cheaper than where they end up. So they end up farther from home and more expensive from home than if they'd gone to a place closer to home. So basically, you've got a situation, people are terrible price shoppers, and price shopping, as we said, is what disciplines competition. Doesn't happen here. As a result, prices are all over the map in healthcare. If you look at figure 15.6, this is quite striking. This is basically for a knee replacement, how much the price varies across hospitals in the US. So the same service across hospitals in the US can basically go from costing less than $10,000 to more than $50,000. Okay, once again, often within the same market. Most of this is not across markets, but within markets. Okay, so it's clearly not effective competition and shopping. Okay, in Tampa, Florida, the most expensive place to get your blood tested, just a simple blood test, costs 40 times as much as the cheapest place, and yet people go to both places. Okay, there's no price shopping, there's no competition in this market. Okay, so that's the second problem we have. We have unregulated prices. We have unregulated prices in a market that's got rife with failures, including a lack of shopping, and therefore you get prices that are too high and too variable. The third problem, and the third biggest segment in this graph, is inefficiently delivered services, or we'll lump it with unnecessary services. Lump the blue and the pink together. Okay. Basically, this was the focus. This was sort of the major focus at the time the Affordable Care Act was passed, was the fact that we do a lot of things that people don't need, and really rarely has one piece of popular writing done more to influence a policy debate than an article by a guy named Atul Gawande, who's a famous doctor and medical writer in the New Yorker in May 2009. So what he did is he did a simple, he went to 2 towns in Texas. One was McAllen, Texas, and one was El Paso, Texas. Both of those cities are very similar in demographic composition, very similar in location, both in South Texas, etc. Yet healthcare spending in McAllen was the most expensive in the country, and El Paso was the national average. McAllen cost twice as much. We got any Texas folks here? You're from McAllen. You go, bro. Okay, I hope I'm not going to rag on anyone you know here. Okay, so basically, why was McAllen more? Well, I'll read from Atul Gawande's article. Between 2001 and 2005, critically ill Medicare patients received almost 50% more special visits in McAllen than El Paso. and were 2/3 more likely to see 10 or more specialists in a 6-month period. Patients in McAllen received 20% more abdominal ultrasounds, 30% more bone density studies, 60% more stress tests, 200% more nerve conduction studies to diagnose carpal tunnel, and 550% more urine flow studies to diagnose prostate troubles. They received 2 to 3 times as many pacemakers, implantable defibrillators, cardiac bypass operations, and coronary artery stents, and 2 to 5 times as many home nurse visits. So care was way more intense in McAllen, Texas. And yet people live no longer. Healthcare outcomes were identical. So you have 2 cities. Your parents doctors?
Yeah.
Uh-oh. Boy, I'm really coming close to home. You have to go back and ask them what they, I'm sure they pay attention to this article. So you have to go back and tell them ask what they think. You can come back, you can call them and report back next time what they thought about this article. I'm sure they have a good defense for it. But you have 2 cities. One city delivers healthcare that's many, many times more intense. And by the way, this is Medicare, which is the same price. There's no price differential here. Same price across these 2 cities for every service. This is a part of this. This is a piece that has regulated prices. Medicare does regulate prices. Yet you have more than twice as much healthcare delivered in one place than another, and no improvement in health outcomes. Okay, so that is basically, and that's a larger sense of what's been found around the country, that there's huge variation in the US in how similar patients are treated. Huge variation in how similar patients are treated. Okay, and basically, it's basically because we don't have any role in the US for evaluating treatments or reimbursing treatments based on their relative effectiveness. A key concept in healthcare around the world is what's called comparative effectiveness. The idea of, are 2 different things equally good at treating a disease? We don't care about that in the US. In the US, we have an FDA whose job, a Federal Food and Drug Administration, whose job is to approve drugs if they're effective and safe. And whose job has nothing to do with whether they're cost effective, just whether they work. So if 2 things both work and one's 100 times more expensive, doesn't matter in the US. Okay, in other countries, which we'll talk about, they won't pay for the one that's more expensive. In the US, we will. What that means is physicians, except for this guy's parents, have an incentive to do the more expensive things. As long as they're not hurting the patient, they can potentially make a lot more money. And that's what we saw in McAllen. So for example, let's look at a couple great examples in the US. One of my favorite example is back surgery. There are 4 different clinical trials showing that spinal fusion surgery is no better than non-surgical treatments for relieving back pain. Yet despite that fact, spinal fusion surgery rates in the US are high and growing. Even more, there is no evidence that intravenous acetaminophen, which is Tylenol, works any better than taking Tylenol by mouth. None. Yet it costs tens of times more, and the use of IV acetaminophen is growing rapidly. Okay, basically, we have a healthcare system where essentially there's lots of opportunities for money to be made, and there's no government regulating to get in the way of that money being made. Yeah.
So is it, so when the doctors prescribe like more expensive use,
Yeah.
Is it paid by the government or like the patient?
Well, we're going to come to that. It's paid sometimes by the government, some by the private sector, sometimes by the private sector. Both of them, in both cases, you make more the more you do. Yeah.
It's because the patient like say no to some more expensive services.
Well, that's a great question. We'll lead to why would the patient want to? Well, they'd only want to if there's some financial burden on them, and that's what we're going to come to. Good questions. Other questions? Okay, so that's the sort of basics of the U.S. healthcare system in a nutshell. We have a healthcare system that's very expensive, that doesn't seem to deliver great outcomes, and that has enormous disparities. So what's going on with the U.S. healthcare system? Well, and in particular, what we'll focus on in this class is not a health economics class, but a public finance class, is what is the role of insurance? What role does insurance play, and how can we design insurance to address these kinds of concerns? So with that as background, I want to turn to talking about optimal insurance in the US. Now, when I talk about optimal insurance, I'm going to talk about it in reference to the concept of cost sharing. So remember, we talked about optimal insurance for unemployment. Over Social Security, we talked about replacement rates. how much of your earnings is replaced by the social insurance. With health insurance, optimal insurance, we use a slightly different concept, which is cost sharing. How much of the cost of your medical care do you bear? Related to this question that was asked. How much of the cost of medical care do you bear? Patients can bear the cost of medical care through 3 different devices. The first is deductibles. A deductible is an amount up to which you pay the cost of your medical care. So you have $1,000 deductible. What that means is when you go to the doctor, you pay the first $1,000 after that insurance kicks in. Alternatively, you can have co-payments. That's what you guys are probably most used to. That's every time you go to the doctor, you pay $25 or $50. Or least common is co-insurance. Which is basically you pay a share of the costs. So you pay, say, 20% of the cost of your visit. So the deductible is 100% co-insurance up to a limit. Co-insurance is like co-insurance is when you pay, say, 20% of the costs, but to a much higher level. Okay. So the bottom line is, how does insurance work? The way insurance works is health insurance works is you pay a monthly premium in return for which the insurer will cover your medical expenses minus what you owe in cost sharing. That's the way health insurance works. And the discussion on optimal health insurance is going to be about what is the optimal cost sharing. Just like the discussion of optimal UI would be what is the optimal replacement rate. Here we'll talk about what is the optimal degree of cost sharing. Okay, and optimal insurance. Now, before we do that, let me talk about how insurance works in the US, because we've gotten a couple of questions. In particular, if you look at table 15.1, this shows you the kind of health insurance we have in America and who has it. So this is currently about 2/3 of Americans have private health insurance, and most of that comes from employers. Relatively little of that is purchased directly. Okay, now, the stuff that's purchased directly, we call non-group insurance. Now, so let's talk about employer insurance. Employer insurance, as I said, is the predominant source of insurance in America today. Typically, employer insurance is provided by firms to workers who are full-time and have worked at the firm for some amount of time. Okay, and basically the way it works is typically employers will pay most of your premium for you. You pay some of the premium. Remember, I talked about the Harvard example in adverse selection, where they changed the share of premiums that people had to pay. So you pay some of the premium, your employer pays most, and you pay the cost sharing. Okay. Now, the first question we want to ask about health insurance is, why are employers in the US the dominant source of insurance coverage? It's not true in most other countries. Why is it true in the US? Well, it's true in the US for 2 reasons. Why are employers dominant? The first reason is risk pooling. The first reason why employers dominate insurance is risk pooling. Remember what insurers are afraid of. Insurers are afraid of adverse selection. Okay. Insurers, they are worried that you're going to come into their office and they're going to offer you a fair price and you're going to turn out to be really sick. So what do insurers want? They want predictability. What insurers want is they want a large group of people where they can use the law of large numbers to predict what their expense is going to be. Insurers are basically pretty conservative. They just want to be middlemen. They just want to say, look, I know what I'm going to have to spend. I'm going to add my 5% profit on top of that and be done for the year. If I take random people off the street, that's hard to do. But if I have a group of 10,000 people and I know their age and gender, I can with fairly high certainty know what their spending is going to be over that year. Some people end up sick who I thought weren't going to be sick. Some people end up healthy who I thought were going to be sick. But as long, it's a normal enough distribution, I can be okay. So what do insurers want? They want large pools of people, and they want pools of people who aren't coming together for reason of health. That is, they don't want a large group of people as the American Skydiving Association. Okay, because that's going to be expensive. They want a large group of people who are brought together for some reason other than their health, which describes workplaces. right? People don't come to MIT because they're healthy or sick. Now, probably the average MIT employee is probably healthier than the average person in America, but it's not why we work at MIT. Okay. Basically, employers are perfect pooling device for insurers. They're big groups where people are brought together for reasons other than their health. And so employers basically provide a kind of great risk pool for insurers. Moreover, some of the costs of insurance are fixed. A lot of the costs of insurance are fixed. So the bigger the risk pool, the lower the fix, more you can spread those fixed costs across people, and the cheaper you can make the insurance. What that means is virtually every large insurer in America today offers insurance. 99% of all employers above 100 employees offer insurance. Okay. But small employers are not as good a deal because they aren't a predictable distribution of risk. And if you employ a firm of 50 people, one guy gets cancer, you can get screwed. So actually insurance coverage is much lower among smaller firms. Prices are much higher and coverage is lower. So among the smallest firms, only about 50% of firms offer health insurance. So health insurance is essentially universally offered if you work at a large firm in America. Okay. And it's only partially offered if you work at a small firm. Okay. And about half of Americans work at small firms in America. So that's one of the reasons why we don't have full coverage. Moreover, even at the large firms, while insurance is offered, they often, as I said, will charge you some of the cost. Okay, so MIT, my family's insurance at MIT costs about $24,000 a year. Okay, of which I pay $8,000. That's a lot. Okay, so some people who offered employer insurance don't take it. That's another reason people sometimes don't have employer insurance. They might not be offered it, or they might not take it, even if they're offered it. Now, that's the first reason why employer insurance is predominant. The second reason is a particular phenomenon to US policy, which is the tax subsidy to employer-sponsored insurance in the US. The tax subsidy. What do I mean by that? That means that when your employer pays you in wages, you are taxed. But your employer pays you in health insurance, you are not taxed. As a result, that is going to bias you towards wanting to get your health insurance from your employer. Let's look at a simple example to illustrate this. Okay, if two people they're in a perfectly competitive, this is table 15.2. They're in a perfectly competitive labor market, and they each have a marginal product which equals their wage of $30,000. Now, let's say that the first person, Nigel, decides not to take insurance from his employer. Okay, so he gets paid the full $30,000. Let's say tax rates are 33%. So he takes home $20,000. Then let's say he goes and buys health insurance for himself at a cost of $4,000. So he ends up on net after tax, after health insurance with $16,000. Now take Kahija. Kahija decides she's going to take insurance from her employer, even though it's more expensive. It's $5,000 instead of the $4,000 Nigel's paying. Even though it's more expensive, she's going to take insurance from her employer. Well, that means that her employer will pay her $5,000 less. It's a perfectly competitive labor market. Your compensation has to equal your marginal product. So if the employer is going to pay you, going to give you $5,000 of health insurance, they're going to pay only $25,000. She's taxed on $25,000. So after tax, she takes home $16,666. She pays nothing on health insurance beyond that. So she ends up with more money. Even though she bought more expensive health insurance, she ends up with more money by getting through her employer. What does this imply? This implies that individuals will want insurance from their employer. It also implies that individuals will be less price sensitive to the cost of that insurance if it's from their employer, because they don't pay with pre-tax dollars, they pay with after-tax dollars. So essentially, if you think Kahija, she's buying health insurance with 67-cent dollars, because if she took her money and bought an apple, it would cost $1. But if she buys health insurance, it only costs 67 cents. So this means both that there'll be a bias towards getting health insurance from your employer, and there'll be a bias towards buying excessively generous health insurance because we subsidized its price. Okay? Questions about that? Okay, so that's employer-sponsored insurance. As I said, going back to table 15.1, the other source of insurance is direct purchase. Direct purchase, by the way, used to be about 40% as big as this number, less than half this number. Okay. What does direct purchase means? That means you literally like go online and buy insurance. You know, Joe Smith goes online and buys insurance. Okay. The problem with that market pre the ACA is that it was a legally discriminatory market. What I mean by that was because insurers faced enormous problems of adverse selection, they were allowed to respond by trying to exclude the sickest from insurance. So for example, it was legal to deny people insurance if they applied. And MIT, if I work for MIT, the insurer can't refuse to insure me. Okay, but if I went as John Gruber and applied to an insurer before the ACA, they could just say, no, thanks. We don't like the cut of your hair. Okay, don't give a reason. They can sort of insure me. Or they could charge me more. For instance, women regularly paid much more for health insurance than men. Or they could exclude my pre-existing conditions. They could say, well, John, you look healthy now, but you had cancer in the past. So if you ever get cancer again, we're not covering that. We'll cover you for something else. But if you break your leg, you're covered. But cancer, we're not covering you. For all those reasons, essentially, if you were a sick person in America who didn't have insurance from your employer or the government, which we'll come to, you essentially were subject to enormous medical risk. If you got sick, you were screwed. So basically, the non-group insurance market was one which worked for healthy people, but didn't work very well for the non-healthy. So before the ACA, when only about 12 or 13 million people were in this market, okay, it's a million people were in this market, it was basically healthy people who were paying cheap premiums. But the minute you got sick, you were out. Okay, so that was the other alternative we had. That's now more than twice as big because the Affordable Care Act got rid of that discrimination. We'll talk about that in a couple of lectures. Okay, any questions about private health insurance? Okay, the other two major sources of health insurance, if you go back to table 15.1, are the two public programs, Medicare and Medicaid. Now, at some point, I may bump into you in a couple of years. Maybe you'll still be at MIT. Maybe we'll just be wandering around. I'll see you. I will not hold you responsible for anything you learn in this course except what I'm about to tell you next, which is the difference between Medicare and Medicaid. It's the only thing I'll hold you responsible for 5 years from now. Medicare is health insurance for the elderly. Medicaid is health insurance for the poor. Now, the split's not quite that neat. Like, what about the poor elderly? They get both, etc. But the bottom line is Medicare is universal coverage for the elderly. Medicaid is coverage for the poor. Okay. So the way Medicare works is it's a universal entitlement at age 65. At age 65, every American gets Medicare. Okay. Medicare is paid for by payroll tax. If you look at your pay stub, you'll see there's a FICA tax. We talked about that. That's for Social Security and disability. There's also a Medicare payroll tax, which, unlike this FICA tax, is not capped. It's 1.45% of your salary all the way up. Your employer also pays another 1.45%. So it adds up to 2.9% of your salary all the way up. No cap. Okay. Anyone who's worked for 10 years in Medicare coverage employment qualifies for Medicare. And their spouse does too if the spouse didn't work. Okay. So there's even bigger spousal benefit here. It's 100% spousal benefit. So if you work 10 years, even if your spouse never works, boom, they're covered by Medicare when you are. Okay. There's no age choice like in Social Security. You just get it at 65. There's no early or late. Basically, and so that the majority, about 85% of those on Medicare are elderly. Now, about 15% are the disabled. Remember, we talked about disability insurance. Well, disability insurance after a 2-year waiting period comes with Medicare. Remember, we talked about waiting periods last time. We talked about the fact there's a 6-month waiting period for disability. Well, there's an even further waiting period, which is even when you get disability, there's a 2-year waiting period to get health insurance with that disability. After 2 years, you get Medicare. So about 15% of spending on Medicare is on the disabled. Okay, so it's about 85% of the elderly, 15% the disabled. That's Medicare. The other is Medicaid, which is for the poor. Okay, Medicaid is basically a program that, like UI, is federally mandated but state administered. Okay, so it's like UI in that sense, federally mandated but state administered. And it's basically for sort of 4 groups. And I'm going to come back in much more, I'll come back in much more detail to these programs in chapter 16. But it's basically 4 groups. The first is if you get cash welfare, we haven't talked about this, so it's in chapter 17. Basically, if you're someone who's getting a cash welfare payout from the government, it comes with Medicaid. If you're a poor person, typically below about 2 times the poverty line or about $50,000 for a family, you get Medicaid for kids and for pregnant moms, children born and unborn, one might say, but not for anyone else. And then if you're a poorer person, in most states below about 133% of the poverty line, you get Medicaid no matter what. So it's basically a program for very poor people or even nearly poor kids and pregnant women. Finally, it's also a program for low-income elders and disabled who are such low income they couldn't qualify for Medicare or disability insurance. They can get Medicaid coverage as well. Okay, I'm going to come back in much more detail. That's just the quick facts on those. So we'll come back in much more detail of those programs. Finally, if you look at the table, there's a third thing called TRICARE Champ VA. That's military health insurance, coverage for those in the military. That's about 3.2% of the US population. Finally, we have the uninsured. Okay, who are they? Well, the uninsured, interestingly, they are not the poorest Americans, because the poorest Americans get Medicaid often. Really, the uninsured are sort of 2 groups. One is sort of near poor, people who don't work for good firms, who work for firms that say don't offer health insurance or don't work. Or poor people who don't take up their entitlement. Remember, we talked about take up last time. A lot of people eligible for Medicaid don't take it up because the language barriers or other reasons. Those are really the bulk. So the uninsured are the very poor, aren't taking up an entitlement, and the near poor who are too rich to qualify for Medicaid, but don't work in a good enough job to get health insurance. Okay, that's sort of who the uninsured are. Okay, indeed, 3/4 of the uninsured are in families with a full-time worker. So it's not like they're basically people out of work. 3/4 of the uninsured are in families with a full-time worker. Okay, and about 1/7 of the uninsured are children. So this raises 2 questions. The first question is, why are people uninsured? And here we have several answers. Okay, one reason is simply go back to the theory from chapter 12, which is that basically full insurance is optimal with a perfect insurance market, with a perfectly competitive insurance market. We don't have a perfectly competitive insurance market. As I mentioned, there's insurance overhead, and there's other problems with this market. As a result, fur insurance will not be optimal when insurers are not zero profit. So it's sort of perfectly rational we'd have some uninsurance in America, given that insurance is not actuarially fair. That's sort of the simplest answer, probably not a very big one. Okay. The second reason is adverse selection. As I said, because of adverse selection, insurers are not pricing actuarially fairly in some contexts. As a result, some people are not getting health insurance. Once again, this was greatly offset by the ACA and a particularly individual mandate, but we'll come back to that. The third reason is basically rational uninsurance. Essentially, to be sexist, roughly speaking, the guys in this class, because they can't get pregnant, really are at almost zero risk of major medical spending in the next couple of years. Basically, sort of guys in your age are indestructible. Okay, women are indestructible too that have this risk of being pregnant. Okay, and so basically, by and large, you guys, health insurance at even fairly low prices is not really worth it. Okay, so a lot of people are sort of rationally uninsured. They basically said, look, it's not worth it for me to uninsured because I'm a young invincible. And so that can explain some of that. Now, part of the reason it's not worth it is because they do get hit by a car. Remember, we're in Cambridge. They do get hit by a car and go to the hospital. They have to be treated by law. There's a law called EMTLA, Emergency Medical Treatment. I forget what, which basically says that a hospital has to treat someone showing up in the emergency room, regardless of whether that person has insurance. A doctor doesn't. You go to a doctor's office, they say, first thing they say is, what's your insurance? You say none, they say, we'll see you later. But a hospital has to. As a result, once again, if you're a young male and the only medical spending issue you have is get hit by a car, and if you get hit by a car, you can just go to the hospital, they'll have to treat you anyway. Why buy insurance? Okay. So there's sort of a degree of rational uninsurance in the US. Okay. Of course, another reason is irrational insurance. Yeah, I'm sorry, go ahead.
If you go to a hospital, will they still charge you for the care?
They'll charge you and they'll try to collect and they have no leverage over you. They can't, there's no debtor's prison in the US. And so basically, what's that?
You just have a really bad score for them.
It will hurt your credit score. But you know, despite the Experian ads, that's not a determinant of one's life's happiness as much as Experian would have you believe. Okay. I mean, I love John Cena and all, but I love the purple cow, but let's be real. I mean, it's not like a primary determinant of happiness in America. So yes, it'll hurt your credit score some, but meantime, if you want to have health insurance, you have to pay all this money. It might be better to just take that risk. I'm not encouraging you. I'm just explaining why it might be rational for some people, but it might also be irrational for a lot of people, because the truth is there is still some risk. And the truth is all of you should be insured at a low enough price. At an affordable price to you, you should be insured because there's still that risk and it will hurt your credit score. And it is inefficient to go to the doctor. I'll talk about it in a few minutes, to wait to go to the hospital when you're sick. So there could be irrational on insurance as well. Okay. So that's why people aren't insured. The more important question from this course perspective is, why do we care? I opened the course with this question. Well, I talked about what's the role of the government in economics. Why do we care if people aren't insured? I'm not delivering a lecture on people not having, you know, HGTVs or beautiful houses or whatever. Why do we care? Well, we care for several reasons. The first reason is externalities, and I covered that in the first lecture. There's both physical externalities, which is if I'm uninsured, I might get you sick. There's also financial externalities, which is exactly what we're just talking about, which is if I'm uninsured and I go to the hospital and get treated, the hospital has to recoup that money somehow. They're going to charge the insured people more to make up for it. So by being uninsured, I'm exerting a financial externality to the tune of pre the ACA about $50 billion a year in uncompensated care. It's now down about a third. Okay, so that's the first reason. The second reason is that it's inefficient, at least the inefficient delivery of care. Let's say you're one of these young invincible guys in this class and you develop a bad cough. And you're like, yeah, the doctor's too expensive. If I end up really sick, I'll just go to the hospital, I'll let it be. And you're really sick and go to the hospital. Okay. Well, it would have been much more efficient for you to see a doctor at $150 than go to the hospital at $10,000. Indeed, one of my favorite facts, they actually did a survey of people in Los Angeles in an emergency room. Now, obviously, this isn't the unconscious people. This is the conscious people. Well, that's most people in the emergency room. And they asked them, would you trade this ER visit for a doctor's visit in 3 days? And almost half said yes. They just because they couldn't go to the doctor, and the ER was covered by uncompensated care. That's inefficient. Those people should be going for a $150 doctor visit, not a several $1,000 hospitalization. That's another reason why we might care. Another reason why I might care is simple paternalism. We think that people are making mistakes, and we want to fix them. I think that people don't appreciate the risks they face. Even you all young invincibles don't appreciate them. So I want to fix that by making sure that you're covered in case these bad circumstances happen. And then finally, a final reason that's quite interesting is we care about the uninsured exactly because of the nature that insurance is tied to jobs in America. And that's the problem of job lock, which is the idea that because the only way to really get good insurance, if you're not poor or old, in America is through an employer, or at least before the ACA it was. We're worried that people with good insurance will be afraid to leave their job because they're afraid of losing the insurance, even if there was a more productive opportunity elsewhere. And that's inefficient. What makes America such a powerful country is we have one of the most mobile labor forces in the world. It's easy to switch jobs here relative to other countries. And that's part of what makes our economy so successful. But if you're unwilling to switch to a more productive position because you're afraid of losing health insurance, that's inefficient. Imagine if people stuck in the wrong jobs because they're afraid of losing their health insurance. So let's do a simple example. Imagine that Emma has a health insurance function of the following form. She has a health insurance function of the following form. U of C comma HI. It's a weird health insurance function where her utility is a function of her consumption and a 1-0 indicator for whether she has health insurance. Okay, that's what she cares about, her consumption and whether she has health insurance. Okay, and suppose she's in a perfectly functioning labor market where her wage equals her marginal product. And suppose further that all employers pay the same thing for health, no, actually, let's go back. So everybody's paid their marginal product net of the cost of health insurance. So if your employer pays you health insurance, they just pay you that much less in wages. Okay. Suppose that Emma works at an accounting firm, which is a big, firm with good benefits. And there she earns marginal product 1. Her marginal product is marginal product 1. But she gets health insurance. But at that firm, she gets health insurance at a cost. She gets health insurance at a cost P. So she's paid MP1 minus P. Let's say now she gets an offer from a startup, which is perfectly matched to her skill set. And if she went there, she could be much more productive. In particular, she would earn MP2, which is greater than MP1, or her marginal product would be higher. So what is her decision? Well, it's quite simple. If she stays in her job, she gets utility of MP1 minus P, which is her consumption, comma 1, which is she has health insurance, versus if she switches jobs, she's utility of MP2, comma 0. We can't sign this inequality. Why? It depends on how much she cares about health insurance relative to consumption. If she doesn't care about health insurance, we can clearly sign this. Clearly, she'd rather switch jobs. But if she's very sick and values health insurance at more than it costs the employer, she won't want to change jobs. Yeah.
It could also be like if she goes to that startup, she could also buy insurance privately, right?
Well, once again, before the ACA, not if she was sick. That's the key point that makes this work. If you had a well-functioning non-group market, this shouldn't be a problem, because then you go buy health insurance on your own for P. But remember, even today, health insurance is much cheaper through employers because there's giant pools. So even today, without discrimination, it's still more expensive to buy it on your own because you don't get the giant pooling benefits you get with employers. Okay. So basically, for those reasons, if she leaves and goes on her own, she's going to have to buy, and she likes health insurance, she have to buy it. It's going to be priced much higher than P, and she could be worse off. So people who really value health insurance might not switch to more productive jobs. Okay. And there's a large empirical literature investigating this, which suggests this job lock is significant. Suggests that among people with health insurance, the job-to-job mobility rate is reduced by about 25% if they don't, because of the lack of health insurance opportunity in another job. So people on their jobs with health insurance are about 25% less likely to move because they don't want to lose the health insurance. Okay, that's a big effect, especially when job mobility is a lot of what drives the dynamism of the US economy. Now, let's be clear. Job lock is not unique to health insurance. Here at MIT, I have river lock. What do I mean by that? I have a spectacular view of the Charles River. Let's say I'd be more productive at Princeton University, and Princeton University made me an offer at a higher wage. Well, I would say, that's great, but I lose my view of the river. Princeton can't get me a view of the river. They're not on the river. So even though I might be more productive at Princeton, I still wouldn't go. I'd have river lock. Basically, anytime there's heterogeneity across firms and their ability to deliver a benefit, you can get this kind of phenomenon. It's just most important and most consequential in the case of health insurance. Okay, questions about that? Okay, that's our background. Now let's come to how should we optimally design insurance? That is, how should we think about cost sharing to consumers in their insurance product? Well, once again, we know from chapter 12 what to do. We just want to pay the consumption smoothing benefits of health insurance against the moral hazard costs of that same insurance. Okay. So basically, what we want to ask is, how do we set optimal cost sharing to weigh those two considerations? Well, consumption smoothing, we actually already know from basic expect utility theory that for most people, the consumption smoothing benefits of insurance aren't very large unless your medical bill's big. relative to your income. Why? Because utility functions are locally flat. If your income's $100,000 and you have a $1 medical cost, you're essentially risk neutral. If you have a $20,000 medical cost, then you start to get much more risk averse. But the point is, if I'm saying to you, what's it worth to cover $1 of medical costs? Well, basically, it's the expected value of that $1 medical cost. So if I have a 10% chance of incurring $1, and you say, would you buy insurance? I say, yeah, if it's less than 10 cents, I'll buy it. For 10 cents, I won't, because I'm risk neutral at that point. But if it's a $50,000 risk, then as we discussed in 1401, and we discussed in chapter 12, I'll be willing to pay a risk premium. I'll be willing to pay more than the cost of insurance for a very big risk. What that means is the consumption smoothing value of insurance rises with the size of the risk relative to your income. A risk that's small relative to your income does not really deliver much value in terms of consumption smoothing. Think of it this way, you're perfectly self-insured against a $1 risk. You all have at least $1 sitting around. So perfectly well insured against a $1 risk. I'm perfectly well insured against a several $1,000 risk. Okay, many of you are probably self-insured well against a several $100 risk. Okay, that is the consumption smoothing benefits insurance basically will start very small and get bigger as the risk gets bigger. Okay, does that make sense? That basically consumption smoothing value of insurance. In other words, we often talk of insurance, we talk about first dollar coverage. First dollar coverage means no cost sharing. So the point is that if you think about first dollar coverage versus a tiny amount of cost sharing, there's literally no consumption smoothing benefit. The consumption smoothing benefit only pops up as the risk gets bigger and bigger. So that's the consumption smoothing side. Once again, you don't need math there. It's just basic intuition of the curvature of utility functions. Now let's think about the moral hazard. Well, the moral hazard, the argument for moral hazard goes back actually to a great article by Martin Feldstein, famous professor at Harvard. They did in 1973. And his argument really can be easily summarized in figure 15.7. Figure 15.7 says, let's imagine that healthcare consists of visits to the doctor. And let's imagine you have a downward sloping demand for visits to the doctor. That is, you're price sensitive. The more expensive the doctor is, the less you'll go. Okay? And let's imagine the marginal cost of a doctor's visit is $100. That's the social marginal cost. That's the blue line. That means that if you pay for every doctor's visit, you will choose Q1 doctor's visits. That is the point at which the social marginal cost equals the social marginal benefit. But now let's say I have insurance, which says, no, you only have to pay $10 every time you go to the doctor. Well, now how many doctors will I choose? Well, for me, my private marginal cost is only 10. So I'll choose Q2 doctor's visits. I will choose more doctor's visits. That will lead to a dead weight loss of the shaded area. Those are the doctors where the marginal cost to society exceeds the marginal benefits to you. You get them anyway because you're not paying the marginal cost to society, you're paying a fraction of that. And that is the basic argument for moral hazard. That basically, because people don't pay the full cost of medical care, they get too much medical care. This argument often leads to something that's referred to as the flat of the healthcare curve argument, which is in figure 15.8. Figure 15.8 is sort of a weird figure. So let me explain this. It's a weird figure because on the x-axis is level and the y-axis is deltas. On the x-axis is every value means what every point in this graph is, what is the health benefit of $1 more of medical spending at that level? So point A says that if you're already spending $1,000, $1 more of health spending delivers $5 in medical benefits. Point B said if you're spending $2,000, this is just made up, by the way. Point B said if you're spending $2,000, $1 more medical spending delivers only $1 more of health benefits. There's a decreasing marginal benefit of healthcare spending. Likewise, if you're already spending $5,000 medical care, the additional dollar delivers 10 cents in medical benefits. Feldstein's argument was we would choose points like point C if we're insured, because why not? There's still some benefit, it only costs me 10 cents. But you're at a point where the extra spending is really doing no good in terms of improving your health. You've passed the point where healthcare spending really is productive in terms of improving your health. Now, basically, this argument is theoretically unimpeachable. When he made it, people were like, that's all well and good, Feldstein. But at the end of the day, healthcare demand is inelastic. People go to the doctor if they're sick. They don't know if they're not sick. And this argument's irrelevant if healthcare's demand is inelastic. As you can see, if that demand curve was vertical, it wouldn't matter what the price was. People go to the doctor whenever they're sick and wouldn't get their weight loss. We'd be the social optimal outcome no matter what. So really came down to the question of how elastic is actually demand for healthcare. And so there became a cottage industry of trying to measure the elasticity of demand for healthcare. So people would run regressions of the form, medical spending is alpha plus beta times, say, your cost sharing. Plus an error term. They'd say, look, do people with higher cost sharing spend more or less on healthcare? And they would find that it looked like people with higher cost sharing did spend a lot more on the people at higher cost sharing spent a lot less on healthcare. People who had plans where it was first dollar spent a lot more in healthcare than people who had plans where it wasn't first dollar, which suggests that this was a very elastic demand curve. Why is that analysis wrong? What's wrong with that analysis from a chapter 3 perspective? What's wrong with the conclusion that, well, gee, yeah.
You have to look at the reasons why they got those types.
Yeah. What if sick people should choose first dollar coverage? So first dollar coverage drives sickness drives first dollar coverage, not first dollar coverage driving sickness. It's a class reverse causality problem. Okay, classic bias problem, which is a set of people choosing different types of insurance. Since insurance choice is endogenous, the set of people choosing generous insurance are going to be sicker than the set of people not choosing generous insurance. That will bias your estimate. So to get at this, we ran probably the single most famous social insurance experiment in the history of the US, which was called the Rand Health Insurance Experiment. In the mid-1970s, they literally randomized people's health insurance. It's Rand not because it's randomized, but Rand because the Rand Corporation did a lot of government contracting work. The Rand Corporation literally randomized people's health insurance. Okay. So what they did is they took people and they randomly assigned them to plans. One plan was essentially free care. You paid almost nothing. Another plan was a high deductible plan. You paid everything up to $1,000, which today equivalently about $5,000 if you look at healthcare inflation. So pretty high deductible plan. Think of it in today's terms as $5,000, you paid everything. And there are plans in between. So they randomized you to these different plans that you could be in. Okay. Now, very important. No one had to spend more than that out of pocket. No one had to spend more than 5,000. Okay, so basically, or 1,000 in 1970s terms. It's basically a question: you either got free healthcare or healthcare could cost you up to $1,000. And importantly, they gave everyone treatments and controls $1,000. So no one was worse off. And since they gave that $1,000 for treatments and controls, there was no bias. Very clever experimental method, right? You can't run an experiment that makes people worse off. That's unethical. So what you do is you pay everyone so no one's worse off. Just some people are relatively better off than others. That's okay. You can do that. You can give gifts. Just can't make people worse off. Okay. What did they find from this randomization? They found that healthcare spending is elastic, but less than these other studies were showing. They estimated an elasticity of demand for healthcare spending of around minus 0.2. That is, every 10% increase in price leads to about 2% less healthcare demanded. Okay. Now, that was the first finding. By the way, this isn't that small a number. If you took this number at the time and applied to the US health insurance system, it implied about $500 billion of deadweight loss from moral hazard. Okay, it's still a big number. It also found, unsurprisingly, that this number varied in ways you'd expect. For example, for what services would you expect this number would be biggest, and for what services would you expect to be smallest, and why? Where do you expect the elasticity of demand for healthcare to be biggest and smallest, and why? Yeah.
I guess would be like preventative.
Preventative.
Yeah.
What else? Even bigger than preventative. What else? Yeah. Elective, dental care, mental health. Those are the biggest. What about least, smallest? Where would it be smallest? Critical surgeries, pregnancy, major surgeries. Okay, basically it's our standard moral hazard argument, right? Moral hazard is going to be worse when the costs of faking it are the lowest and the observability is the lowest. Okay, well, it's pretty easy to observe someone's going to have a baby and no one wants to go have a baby for fun. There's no moral hazard there. There's a lot of moral hazard with things like mental health and dental treatments and things like that. Okay, and the RAND insurance exactly found that. Okay, so that was the first thing it found. The second thing it found was it went after the question you should immediately ask, which is, well, just like we talked about unemployment insurance. Remember we said in unemployment insurance, just because people stay unemployed longer, it doesn't mean it's a bad thing, because maybe people are getting better jobs. You can say the same question here. Is it bad that people are getting more health insurance when it's cheaper, more health care is cheaper? No, maybe it's valuable. We said preventive care. Preventive care is elastic. Maybe it's a bad thing that people aren't getting preventive care. So maybe, in fact, yes, we spend more generous health insurance, but maybe it improves health. But RAND could measure that. They went in because they randomized, actually measured people's health. They did very detailed. They took people's blood pressure, etc. And what they found was overall, there was no effect on health. That the people in the less generous plans spent less on healthcare and were equally healthy. That it literally looked like we're on the flat of the curve. Yeah.
I guess like if the reasons that they're getting the health care is unobservable, how would you observe it?
When you just look at it's just like the same thing with, remember the unemployment insurance? We said, well, maybe it's worth it to get a better job. How do we test that? We look at their wages. Here you'd say, well, maybe it's better if they get health insurance, if they get health care, it improves their health. How do you test that? You look at their health, and there's no effect on health. So basically, just like we concluded people are sitting around on couches unemployed, here we conclude people are getting health care doesn't do them any good, because we randomly got them less health care and they're no healthier. Therefore, the health care they got wasn't doing them any good.
I guess my question is like, what measures of that? Like, how do you measure like mental?
You measure both self-reported health and physiological measures like blood pressure and other things. Blood sugar, blood pressure, other physiological measures of health. So every to the extent you can measure it. Now, it's not perfect. You only measure for 5 years. Maybe the effects show up after 5 years. Maybe there's other measures, but the bottom line is certainly doesn't look like there's a huge benefit. It looks like this is pure moral hazard. It looks like in figure 15.8, we are on the flat of the curve. Okay. And indeed, there's a lot of studies since, such as the one that's covered in figure 15.9, which take different approaches, don't run actual social experiments, but take quasi-experimental approaches to look at the effects of health insurance generosity and health. So here's a great study from Japan, where basically the cost of going to the hospital, co-payments for going to the hospital dropped dramatically at age 70. This is the hospital, by the way. This should be one of the least elastic services. And yet they find that basically, it's the cost of all coverage, I'm sorry. They find that basically inpatient and outpatient visits go up at age 70 when they suddenly get cheaper. Okay, it's pretty flat and then it jumps at age 70. This is the kind of regression discontinuity design we talked about before. So the bottom line is there's basically a lot of evidence since RAND, which suggests that healthcare spending is price elastic. Indeed, if you take this study and do the estimates, they get about minus 0.2 as their elasticity. So RAND elasticity is starting to take the feature of sort of a universal constant, and that lots of articles have tried different quasi-experimental methods and they all get similar answers, which is healthcare is elastic, but not super elastic. Okay. Yeah.
But fundamentally, like not mathematically, like where does this elastic constant come from? Because especially like it's universal, there's something about like human brain that treats.
Oh, I wouldn't go that far. It's just basically people have an underlying utility function which trades off their dollars against their health, and their dollars against, well, not their health, but their dollars against the demand for care. That basically I have sort of, look, when I teach this, the way I teach it, the way I think it was quite simple, which is about 5 or 6 years ago, I hurt my knee playing tennis. And a couple weeks later, it hurt. And my wife was like, look, you should go, it's the weekend, but it's already, you should go get it checked out at the ER. I'm like, I don't want to. She's like, you should go check it out. I looked it up. I was going to $50 copay to go. So I went, they checked it out. They looked at the x-rays. They said, stop being such a whiny bitch. Your knee is fine. Go home. It'll be fine in a couple of weeks. And it was. If I'd looked it up and it was $500, I would have said, no, I'm going to wait a couple of weeks. Okay. So basically we can all think that way, right? It's all just about how you trade off the perceived benefits of healthcare versus the money you have to spend. Okay, so basically, that evidence is pretty conclusive. But there is one wrinkle, which is quite interesting, which is the Rand health insurance experiment suggested the evidence was statistically weak, but it suggested that there may be one group for whom having more generous insurance does improve health. And that was low-income people who were chronically ill. So say with someone with diabetes or high blood pressure or other things. And the reason it might matter for that group is because people who are chronically ill, there are cost-effective interventions to maintain disease. For instance, if you're diabetes, you can take a pill that costs $1 a day that'll keep you from getting your foot amputated. But low-income people couldn't afford those unless they were fully insured. And actually, there's been a lot of interesting evidence since, which has suggested that basically it is true that people are not getting necessarily the care they need if they're low income, and it's costly. It's very cost effective care. Okay, so what this suggests, okay, what this suggests is that optimal health insurance, what Feldstein concluded is still largely true to first order. Feldstein concluded is, look, that first dollar health insurance coverage is never optimal. Just like 100% Social Security replacement rate would never be optimal, first dollar health insurance coverage is never optimal because the consumption smoothing benefits are small and the moral hazard effects are large. If you have someone with no cost sharing, they'll be way out to the right in figure 15.8. Okay, way out to the right where there's very little health benefit, and they won't be getting any consumption smoothing. So basically, that is inefficient. Feldstein suggested that optimal insurance should have significant cost sharing, but there is room for recognizing that there are populations where that may not be true. Feldstein even recognized this. He even suggested something which he unfortunately named at the time, not foreseeing technological advance, he named major risk insurance, which he thought would be a great acronym. Major risk insurance, get it? Okay, whatever. Yes, tough crowd. So basically, and his idea was everyone should have to pay 50% of the cost of their insurance, of their cost of medical care, I'm sorry, until they've hit 10% of their income. His idea was, look, everyone pays 50% of the medical costs until they've had 10% of income. That way you balance moral hazard and consumption smoothing. At low expenditures, where there's not a lot of consumption smoothing, a lot of moral hazard, you basically make sure people don't have to pay it. But at high expenditures, where, emergency giant surgeries and things, we think moral hazard is probably low and consumption smoothing's big, then we basically think people should, we should cover it, but it should be proportionate income. A very rich person, a $5,000 expenditure is still small. A very poor person, a $100 expenditure can be quite big. So it should be a function of income. I think basically the logic today to the optimal health insurance is a lot of discussion of what we call value-based insurance design. And the idea here would be to take Feldstein's insight one step further. Take Feldstein's insight one step further, okay? Which is that basically to essentially say not only should we vary cost sharing with income, we should vary it with your characteristics. So for example, low income diabetics, they should get totally free treatment for their diabetes. Maybe even high income diabetics. Basically, treating diabetes is actually not just cost effective, it's actually cost saving. If people take their diabetes treatments, we actually net save money because the cost of pills is so cheap and otherwise you get your foot amputated and that costs a ton of money. So basically would say we should literally have cost sharing targeted, not just by income, but by disease. In the limit, you would literally have disease specific, income specific cost sharing. They'll go to you, they do an evaluation, what's wrong with you. Say, based on what's wrong with you, here's your cost sharing. Now in practice, it's very hard to do. Okay, I had a great story about that, sort of the difficulties of translating academia to reality. I was on the board, so I was on the board that basically set up universal coverage in Massachusetts, where 10 people were charged with determining what insurance should look like for Massachusetts, which was a pretty broad task. And I said, well, this is awesome. This is a chance to apply the principles of value-based insurance design. So I called the guy who came up with this. I'm not going to give his name. Called him up and I said, hey, we have a chance to set up value-based insurance design for hundreds of thousands of people. What should we do? He said, oh, that's great. You should set high co-payments for low-value services and low co-payments for high-value services. I said, that's fantastic. Great idea. So how should we do it? He said, well, you should set high co-payments for low-value services and low cost, and he had no idea what to actually do. And the problem is it turns out to be hard. It turns out there's not that many services we know for sure are low value or high value. It's a very small subset. Most things are sort of vague and in the middle. So it turns out, and it's also true, like who decides what's high value and low value? It could vary for different populations, etc. So we theoretically, we know what optimal insurance should look like. Optimal insurance should be, okay, optimal insurance should be something where you make people pay for their cost of healthcare in proportion to their income and their underlying medical need. Okay, that's pretty vague. What we'll do, we'll talk about next time, we'll talk about what we've actually done in the US and how close we've come. But that would be sort of, in theory, what we should do. Now, until about 10 years ago, we did not do that at all. It's changed, but I used to have a diagram in my book, which was of the form, which was like on the x-axis was sort of American population, and the y-axis was generosity of insurance. And we had something like, 250 million people with insurance. Let's say this was optimal insurance generosity, like 250 million people with insurance that was too generous, and then 50 million uninsured with no insurance. And it's like there was this giant missing middle. Why aren't there people with kind of generous insurance? Now that's changed. I'll talk about that next time. But one answer why this middle is somewhat still missing is the tax subsidy to health insurance. Remember that when I go to buy health insurance through my employer, I don't want optimal health insurance because I'm being subsidized. I want better than optimal health insurance. If I was buying with my own dollars, I wouldn't want to buy health insurance that's optimal. If I'm buying with pre-tax dollars, I want health insurance that's optimal plus some. I want it somewhat better. So part of the reason health insurance is very generous in the US is because we tax subsidize it. By the way, that tax subsidy costs the US taxpayer $300 billion every single year. Okay, so we have a $300 billion subsidy to individuals that cause them to buy excessively generous insurance. Okay, and we will talk some about that, about what we should do about that when we get to tax healthcare reform in chapter 16. So we're going to just stop here. I'm going to come back and finish chapter 15 next time, probably take about the first third of the lecture, and then I'll go on to chapter 16. We'll get about halfway through chapter 16, then we'll come back to the next lecture talking about healthcare reform.